Welcome, everyone. Welcome. I am here to introduce our third section of or third portion of our webinar, Geographic Origins, Diagnosis, and Treatment of Hereditary Amyloidosis in African Americans. Hereditary Amyloidosis in African Americans, an educational series brought to you by the Southern Nevada Black Nurses Association with support from Pfizer. Next slide, please. We're sponsored by Southern Nevada Black Nurses Association. My name is Dr. Tracy Johnson Glover. I'm the Vice President of our local chapter in Southern Nevada. Our mission, we are advocates for Black healthcare consumers. We act as health change agents, and we serve as the national nursing body to influence legislation and policy, which is why we are presenting this forum so that we can learn more about HATTR.
Wonderful. Thank you, Dr. Johnson Glover. My name is Dr. Rachel Hendricks Stirrup. I've joined the SNBNA on this mission for actually a few years now. We've worked together very closely to put this content together for you today, and very happy to have anyone tuning in, happy to have your interest. So just to give you a little bit of background on why this work is important, really there's an overall lack of ethnic diversity in clinical research, especially genomic medicine research. We've noted, and others have noted as well, that 78% of data used in genome-wide association studies come from people of European descent, even though this population in and of itself only comprises 16% of the global population. So this glaring lack of representation in the GWAS database has resulted in a lack of data that could help foster a greater and stronger understanding about gene-disease relationships within diverse African Americans. Here today, we will focus on hereditary cardiac amyloidosis, or HATTR amyloidosis, as an important use case to highlight the importance of African American community engagement in genomic medicine research. And so, as I mentioned at the top of this slide, we've gone on a mission to engage African American nursing professionals and others in discussions about genomic medicine research, really with the goal to identify and characterize their concerns about engagement and participation in this type of research. We were fortunate enough to publish our work on this topic last year in the AMA Journal of Ethics. The title of the paper, as you see here, is African American Nurses' Perspectives on Genomic Medicine Research. We conducted some interviews with members of the broader National Black Nurses Association community, conducted a qualitative analysis to understand, or at least confirm, some concerns that we knew, and understand some new concerns that they might have had that were not discoverable in the literature. And from that, we took those concerns and came up with actionable strategies to inform policy and other efforts, engagement efforts, on ways to address these concerns to foster stronger engagement among the African American community in genomic medicine research through the eyes and lenses and experiences of African American nursing professionals. So I'm really happy to share this work with you. Really happy to guide you to this publication as you see it here. It is available open access on the AMA Journal of Ethics website. And I will add this work that we did was a collaboration between the Southern Nevada Black Nurses Association, or SNBNA, and my former institution, the Harvard Pilgrim Healthcare Institute. I am very excited today to present our presenters, or introduce our presenters, Dr. Altavis Ewing, who's a genomic health equity scientist and licensed certified genetic counselor. She will present on hereditary transthyretin-related amyloidosis cardiomyopathy disparities and the role of genetics in genomic services. Also very excited to introduce Dr. Johanna Fajardo, who's an advanced heart failure practitioner, infiltrative on the topic or practice of infiltrative cardiomyopathy. She's the program director overseeing this particular program at her institution, and she will present today cardiac amyloidosis symptom management. So without further ado, I'll turn it over to you, Dr. Ewing, to give your presentation.
Thank you so much. I am truly honored to be here today to share some information about a condition that's near and dear to my heart. And thank you very much to the Southern Nevada Black Nurses Association for the invitation today. Next slide, please. And just to quickly disclose, I am a full-time employee of Roche Genentech, as well as a consultant with the Genomes to People Consortium and a founder of Ingenuity LLC. The objectives for today will include presenting or reviewing, in some cases, the genetic characteristics of hereditary transthyretin-related amyloidosis, cardiomyopathy, as well as provide some additional information about TTR, P.V142I variant, also known as V122I. I will also provide details about genetic counseling and the current return of result recommendations for TTR. And lastly, end with a discussion of the inequities that ensue from current recommendations around the disclosure of TTR genetic testing results. Next slide, please. And now I'll move into a genetic overview for TTR amyloidosis, also known as HATTR. So it's really what we consider to be a spectrum condition. To date, there are more than 130 variants or mutations identified in the TTR gene that are responsible for the presentation of a variety of different symptoms in HATTR. As you can see on the screen, here is a picture of a number of the variants that are responsible for the phenotypic presentation associated with HATTR. And as you can see, the variants are actually ordered in the degree of severity. So I'd like to draw your attention to the V122I variant, which I will focus on today. And this is a variant that is significantly associated with cardiac features, oftentimes heart failure or cardiomyopathy. But as you can see, an individual who has any one of these variants in the TTR gene can present with a variety of neurological symptoms, ranging all the way to cardiac symptoms. And at times, some patients may actually present with a combination of the two. And HATTR-CM is actually one of those conditions where we get to use a number of terms in our genetic vernacular. It's known as a pleiotropic condition. So this means that one single gene is actually responsible for a disease that presents with a wide range of symptoms. It's also known as what we call a incomplete penetrant condition. Penetrance just refers to the likelihood that a clinical condition will occur if there is a mutation in a particular gene. So if someone has a variant or a mutation in the TTR gene, what is the likelihood that they will present with symptoms, or the likelihood that they will not present with symptoms? And as a result, we call this a condition of reduced penetrance, because not everyone with a variant in the TTR gene will actually present with neurological or cardiac symptoms. And lastly, this condition is also characterized by what we term variable expressivity. And this is referring to the series of signs and symptoms that may occur in different people with the condition with the same genetic condition. Next slide, please. So on this slide, we have an image of the transthyretin protein. This is a protein that is typically produced in the liver. However, there are some components of the protein that are actually produced in the brain as well. And in the normative form, in the normative character state, the transthyretin protein is comprised of 4 subunits that make it a homotetramer. And when this protein dissociates, it actually breaks down into 4 different monomers. And those monomers can take on a conformational shape that is relatively unstable and can actually accumulate in toxic levels throughout various parts of the body. And today, again, we will focus on the transthyretin P.valine 142 isoleucine variant, P dot standing for the protein number, but this variant is commonly known as V122I. And the mutation that is present within the V122, within the TTR gene is actually what we call a missense mutation. And additionally, this V122I variant is commonly identified in people of West African or of African ancestry, and oftentimes, as I mentioned, associated with cardiomyopathy. Next slide, please. So I'd like to quickly just cover some of the clinical genetic services that are available for patients and families who are identified to have a V122I variant, or who oftentimes may present with symptoms associated with Hatter or Hatter-CM and may not necessarily have a diagnosis of the condition. So I'd like to start with a clinician that a number of people may not be aware of, and these are genetic counselors. I myself being one of the 5,000 genetic counselors certified throughout the nation. So as you may or may not know, as genetic counselors, we are not medical doctors, but we can play a critically important role in one's healthcare management. We are oftentimes specialized in prenatal, pediatric, oncology, neurology, ophthalmology, and a variety of different areas, as well as cardiology, hence the presentation today. Oftentimes we will see patients in person, but due to the lack of genetic counselors distributed evenly throughout the nation, a number of us actually see patients via telehealth services. And also, in addition to the specialty areas, we may oftentimes work in the capacity of laboratories. We may serve as directors of various genetic counseling programs. Some of us are heavily engaged and involved in research, education, industry, marketing, and a number of what we consider non-traditional roles for genetic counselors today. Next slide, please. But genetic counselors can be very informative in providing details and supporting information, in providing support to individuals as well as families who may have a genetic condition or who may be at increased risk of various genetic conditions. So during the genetic counseling session, one will more than likely discuss the genetic risk for disease, the disease of interest, discuss the risks and benefits of genetic testing, as well as determine if a patient who is meeting with the counselor is the best person in that family to offer genetic testing to. We oftentimes review family health history with patients. We will discuss conditions, inheritance, and transmission patterns, as well as discuss other family members who may be at risk for developing the condition of interest, or even, as I mentioned, determining if there may be another family member who is more appropriate to test in that family during that time. We also equip patients with communication strategies to share information in order to share information with their relatives about the disease of interest. We oftentimes will talk to our patients about research options, such as clinical trials that are available. And again, lastly, provide that, that support as well as resource information to patients. Next slide, please. And just to bring it back to Hatter-CM or hereditary amyloidosis, it's a condition described as an autosomal condition. So this means that the condition will present equally in men and women. So it's not necessarily associated with one particular sex or another. Autosomal dominant conditions oftentimes do not skip generations. However, we do not always see that each subsequent generation will have an individual who presents with the condition of interest. And sometimes that may be a result of a small family structure, or just a function of the fact that the variant was not passed on to subsequent generations. And then lastly, there are times where we may see that a condition may all of a sudden appear within a family, and there may not have been another relative in the family with the same condition. And these are oftentimes attributed to what we call de novo mutations or variants, or brand new mutations, which can occur anytime we have replication. And as I mentioned earlier, this is a condition of incomplete penetrance or reduced penetrance, a pleiotropic condition, and variable expressivity. So just because individuals have a variant detected in the TTR gene, it does not mean that they will present with the same exact symptoms. They may present with a variety of different symptoms, and their symptoms could look very different from another patient who has the exact same variant. Next slide, please. And as I mentioned, if one has the opportunity to meet with a genetic counselor, or hopefully when you're meeting with other healthcare providers, you have an opportunity to talk about the importance of family health history as it pertains to HATTR-CM. So some of the questions that a genetic counselor or a provider may ask you to really determine or assess your risk for HATTR-CM may include, is there a known mutation or variant already detected in the family? And this is informative because if we know the source of the condition, if we know the cause of the presentation of the condition in the family, then we can go right to that source and immediately test other family members for that same variant, as opposed to ordering maybe a broader test and a more extensive test. So this targeted approach can be much quicker, and it can be less cost prohibitive as well. An individual may also ask if there have been any sudden deaths in the family that you or other family members are aware of. It is not uncommon for individuals to also inquire about the family health history of heart failure, individuals in the family who present with a shortness of breath, some of the medications that individuals may be on, including diuretics, other conditions such as hypotension. Individuals may also ask about the ability to tolerate certain medicines, and even if someone is prescribed a medication, how effective that medicine has been in treating their conditions. And then lastly, it could be informative to share information around inconclusive or abnormal echocardiogram results for that patient or for other family members as well. And then if there is a presentation of heart disease or heart failure within the family, knowing that age of onset could be informative as well. And then some of the last questions that you may have to answer around the family history of HATTR-CM include if there is a prevalent history of carpal tunnel syndrome, because this is one of the symptoms or syndromes that is associated with hereditary amyloidosis. And again, understanding what the presentation of symptoms are in the family, as well as the severity of the combination of those various symptoms, can be informative. Next slide, please. And here I just wanted to provide a quick description of the types of results that one may receive when they undergo genetic testing. So if one undergoes genetic testing, it's possible that you may receive a positive result, meaning that there was the detection of a change in one's gene or the detection of a genetic variant associated with the disease of interest. One may receive a negative result, and this simply means that there was not a variant detected in the gene of interest. However, negative genetic testing results should be interpreted carefully and within the context of family and personal health history. And that's because as our knowledge of genetic contributions to disease increases, the panels, the tests that are available to us, the ones that will be made available to patients, they will only improve over time, and they will at times become more comprehensive. So it's possible that you could have had a genetic test years ago that did not look for a specific sequence change or a specific variant that we may be capable of testing you for today. So it's always great to interpret those negative genetic testing results within the context of your personal and family health history. And then lastly, one may receive a result known as a variant of unknown significance, or a VUS for short. And this just simply means that there was a change detected in your gene of interest. However, we do not have enough information right now to fully understand if that gene change is responsible for the presentation of your symptoms, or if it is a benign and harmless change that just makes you uniquely you. Next slide, please. When it comes to the genetic testing for HATTR, oftentimes the tests that are made available include TTR specific site analysis. Again, that's going directly to the source. If we know a gene change that's present in the family, we can go directly to that source within the TTR gene to look to see if it is present. And then it may also include TTR analysis, and that's where we are performing more of that sequencing analysis, where we're basically looking at every single sequence within that TTR gene. Some of the values and benefits around genetic testing for HATTR include the fact that if we are able to offer genetic testing, it could actually confirm a suspected diagnosis and prompt more precise treatment for patients and for family members. It also allows us to differentiate between the type of amyloidosis condition that one has. It also enables us to offer treatment and screening based on the genetic subtype. Again, individuals may present with different symptoms based on their genotype or their genetic change. So some of those treatments and screening recommendations may be more appropriate based on your genetic change. It will also allow us to determine carrier status for a known familial mutation. And lastly, it will also enable us to potentially provide a diagnosis sooner to individual and start clinical monitoring sooner as well. Next slide, please. However, when we think about HATTR-CM and we think about hereditary amyloidosis in general, genetics alone is not enough. So genetics is oftentimes coupled with diagnostic information. So in order for one to receive a diagnosis of HATTR-CM or hereditary amyloidosis, they oftentimes have to undergo confirmatory diagnostic testing coupled with genetic testing to identify that there is a variant that is explaining the presentation of that symptom. And additionally, molecular confirmation of a diagnosis helps us to ensure that we're not ordering unnecessary tests or even procedures, which can be very demanding and taxing to a patient as well as their family member. That molecular testing can help, again, refine and guide the recommendations for medical treatment and screening, as well as offer genetic counseling for the entire family. So there are several benefits and value associated with genetic testing. Next slide, please. And in the next slide, I just wanted to highlight some of the expert curation panels that exist, as well as some of the organizing bodies that have presented information in terms of how TTR status, TTR genetic testing results should be disclosed and when they should be disclosed to individuals. So if we focus on ClinGen, which is sponsored by the National Institutes of Health, ClinGen being short for clinical genome, it was founded in 2013 by the National Human Genome Research Institute. And this is a panel of experts who have really come together in order to identify those human genes that when they are altered or when they are changed, actually increase the risk of the presentation of a serious disease that could potentially be prevented or even mitigated if we are aware that that risk is present. This panel oftentimes evaluates genes with a semi-quantitative metric. They oftentimes look at the severity of the gene, the likelihood of the severity of outcomes, as well as the effectiveness and riskiness of actually intervening when someone has a variant. The American College of Medical Genetics and Genomics is another body that also focuses on the provision of recommendations around genetic testing result disclosure. And they oftentimes will prioritize certain genes that should be disclosed to individuals, oftentimes during research or clinical whole genome and whole exome sequencing. So the ACMG oftentimes looks at various genes to determine those priority genes through an ethical framework. Their recommendations are oftentimes applied in an investigatory setting, so in a research setting, and it's really, again, to help guide the return of genetic variants for which there may be information around risk mitigation or even treatment options that are available to individuals. So you may see that individuals involved in biobanking research or other longitudinal studies may actually adhere to the ACMG return of result guidelines. And actually to date, and this is currently outdated, but ACMG to date recommends return of result for 73 actionable genes. So it's actually known as the ACMG 73 right now. And again, this is oftentimes the case when clinical exome and clinical genome sequencing are ordered. And again, I just want to emphasize that to date, it is based on 73 genes. And that information is dynamic and it may change annually and will oftentimes be a function of the genes that the panel is actually it reviews. Next slide, please. And we can actually skip this slide as well. So just to close out, I wanted to bring to your attention some of the disparities that exist within Hatter, CM, Hatter in general, hereditary amyloidosis. Next slide. So when we focus on Hatter, CM, and the disparities, sorry, if you can go back one slide, please. And the disparities that exist within Hatter, CM, is the condition that disproportionately affects individuals of African descent within the US, but also individuals of African descent around the world. This condition is 4 times more common among people who identify as Black relative to individuals who identify as white or oftentimes of European ancestry. And again, as I highlighted, the V122I, also known as P-dot valine 142 isoleucine variant, it is oftentimes associated with cardioamyloidosis and is actually estimated with a prevalence of 3 to 4% in people of African descent as well as West African descent. So that means 3 to 4% of people within the US, as well as people who identify as West African or of West African ancestry, actually carry this variant and may not be aware of their genotype status. Hatter CM and Hatter in general is a condition that is oftentimes underdiagnosed. Some patients may actually be misdiagnosed with other conditions. And this actually does, at times, it leads to a disservice in the ability to appropriately provide precise and accurate care to patients or even their family members, as some individuals do find themselves embarking upon a diagnostic odyssey to try to arrive at a diagnosis. But again, because it is a condition that's currently labeled as rare, because a lot of clinicians are unaware of the condition, it oftentimes leads to that underdiagnosis among people of African descent and others who present with the variant in the condition. And then I also wanted to highlight that in 2019, the FDA approved of a treatment known as tafamidis, which is highly actionable in treating Hatter CM specifically. But prior to that, there was not a medication that really targeted the cardiomyopathy form of hereditary amyloidosis. Next slide, please. And I just wanted to highlight that when we think about disparities in genomic medicine, they exist all along the healthcare continuum. So they may exist in terms, you may find that disparities exist in the collection of that family health history that's used to construct the pedigree. We may see that disparities exist in terms of who is referred for genetic services and who has the option to see a genetic counselor or a genetic medicine clinician. We may also see that, again, the underrepresentation of certain populations in research leads to more limited therapies and more limited resources and products that are not as effective in diagnosing, helping to prevent or even treat some of the genetic conditions for underrepresented populations. Next slide. And when we think about some of the racial, ethnic, and ancestral differences that exist within genomic medicine, it oftentimes mirrors some of those same disparities that we see in other specialty areas too. So when we think about people of African descent, African ancestry, again, we are more likely to be underdiagnosed when it comes to Hatter CM or even misdiagnosed with other conditions that may present with a similar symptomatology. But again, that lack of awareness around the condition, it permeates and pervades medicine and leads to the inability to diagnose people with the appropriate condition. But when we think about some of our common genetic practices in terms of what is the information that we are collecting during that clinical intake process, during that genetic counseling process, it's not always standard. We are not always collecting information regarding race, ethnicity, and ancestry. We are not always collecting that 3 pedigree family health history. We're not always asking the right questions. And this really limits our ability to deliver on equitable and precise care for more underrepresented populations. Next slide, please. And then just to bring you back to that genetic testing result, with the 3 types of results that one can receive, including that positive, negative, and that variant of unknown significance, we oftentimes see that a VUS will be more common among those underrepresented populations. And this is a direct function of who we are studying and whose DNA we are studying, and what insights we have been able to generate based on the data that is available to us. And although VUSs can be reclassified based on our growing knowledge around the association of that VUS with disease, or that association with a VUS with benign status. But again, that has to be a priority of the scientists who are studying that particular condition. And it, again, will also be a function of if we have access to more data that is reflective of those underrepresented populations. Next slide, please. And unfortunately, when we think about some of the profound landmark studies that have really revealed some of the inequities that exist in the unequal treatment practices in medicine, it is no different when it comes to genomic medicine to date. So this slide, I have an image of an unequal treatment that was comprised, the report that was comprised in 2003 by the Institute of Medicine. And then to the right, I have an image of the most recent ACMG, American College of Medical Genetics and Genomics secondary findings list, again, reporting those genes that should be disclosed to patients when they undergo clinical sequencing, exome or genome sequencing. And again, to date, this ACMG recommendation is based on the return of 73 genes. And unfortunately, TTR is not included in that list of 73. And I really think right now that is a missed opportunity to deliver on equity, because we know that this is a gene where certain variants do cause a more severe presentation of symptoms and associated with cardiac symptoms, which we know the majority of people within the US, and when we think about disparities among vulnerable and underrepresented populations, cardiac disparities is at the top of the list. And unfortunately, TTR is not one of those genes that is recommended in a clinical exome or clinical genome setting to be returned to patients. But hopefully that recommendation will change, as I and others have been very outspoken and very passionate about just emphasizing how this is an opportunity for us to deliver on equity, possibly reduce, if not eliminate, some of the disparities that we see in groups when it comes to cardiac care. And the next slide, please. And next slide, please. And just to close out, as Rachel mentioned earlier, there are disparities that exist within the current state of genetic research, with the majority of people who have undergone whole genome-wide association studies, the majority of those people being of European ancestry. And again, that is not reflective of the majority of people on the globe. So we are not studying the majority of the world, but there are benefits to participating in research. And we must do a much better job of ensuring that the underrepresented are better represented in research, because ultimately it will refine our understanding of the clinical presentation of diseases as we know it in certain populations. It's going to enable us to better understand disease risk management as well as clinical outcomes. It will also help us detect more of those clinically significant changes or variants that may present, and possibly identify those earlier. But we will only know if those clinically significant variants are the same in each and every population if we are including every population. And then additionally, it will enable us to better be able to prevent various diseases and ultimately be able to deliver on health equity. Next slide, please. And in this slide, I wanted to highlight a study that I have the pleasure of being involved in. But again, it's a study where currently it's a missed opportunity to be able to deliver on health equity. The POP-seq study is a study led by investigators out of the Genome to Sequence Consortium, where the aim is really to really assess some of our knowledge gaps that exist around the benefits and the harms of returning genetic testing results to patients, patients as well as research participants. And through returning this information, it will enable us to ultimately develop a framework that will help guide the way that research is conducted, but eventually the way that medicine is practiced. And hopefully this is something that will become a standard. And with that being said, this is something that we need to take an equitable approach on, especially as it is starting in the research setting with the aim and intent of becoming standardized throughout medicine. But the POP-seq study is very uniquely poised to help address health disparities, especially as it pertains to Hatter-CM and various conditions, because it's a study that is a partnership between Genomes to People as well as investigators from the Framingham Heart Study, as well as the Jackson Heart Study based out of Jackson, Mississippi. And the aim of this study is to return genetic testing results based on the ACMG 59. So it's not even the ACMG 73, which is the most current recommendation, but instead the return of those 59 variants that were deemed to be of critical significance in 2017, return those results to patients, and then assess how patients handle that information, and if they use that information to inform their medical management and their decisions moving forward, as well as assess whether or not the return of that information may lead to better care that is provided by various clinicians. So just wanted to, again, highlight this as a study that is uniquely poised to help address disparities and inequities within genetic medicine, but also highlight that it is a study that's not perfect to date, and one where we do have much room for improvement, especially if we are to take a more equitable approach and lens in ensuring that the outcomes generated from the study enable everyone to benefit from our growing knowledge of genetics and genomics and the advancements. And then for the last slide, I just wanted to end by highlighting that when we think about who is participating in research and who is not participating in research, if you'll go to the next slide, please. It is critically important that the inclusion of diverse and underrepresented populations in clinical research and real-world databases, this inclusion will be paramount in our ability to make healthcare equity a reality for all. So it's important that we are studying everyone, that we've collected data from everyone through informed consent, of course, because this data that we collect will ultimately inform the care, inform the development of products, of therapies and interventions that are developed. So thank you all very much for your time.
Thank you so much, Dr. Ewing. This was a wonderful presentation. I've learned a lot. I hope those of you joining us have also learned a lot. And I am happy to now stop sharing my screen and turn it over to our next presenter, Dr. Johanna Fajardo. You may have the floor.
Okay, great, thank you. I'm gonna share my screen now. All right, are you guys able to see my slides? I can't hear you. Yeah.
Yes, we can see your slides, although I think you have it in the back end mode. If you want to, I don't know if you want to leave it here or change it to a different.
Yeah, so you see the notes and not the main presentation?
Yes.
How do I change that?
Maybe, okay, so try exiting.
Okay.
From this view, and then
Johanna, if you are you on two screens?
I'm sorry?
Are you looking at two screens?
I have two screens, yeah.
Okay, so you might just click your share screen and pick the screen that you remember being, you'll see a green border around it. That's the one that the Zoom wants to share. So just pick the screen as your full slide.
Excellent, thank you. I will try that.
Yeah, I do think you click the same presentation mode though here in PowerPoint.
Yes.
There we go.
You just want to.
There we are. Okay,
I forgot.
wonderful. We've got it.
This is why I asked if it was gonna be edited, because I always go through this. Thank
Yeah,
you.
It will be.
All right, well, thank you so much for the invitation. It's really an honor to speak to all of you today. So I'm going to be speaking about cardiac amyloidosis symptom management. I know the topic for this conference is particularly hereditary transthyretin amyloidosis. I'm going to be focusing on the cardiac implications of amyloidosis infiltration in the heart. So for disclosures, I have participated in several nursing advisory boards in different pharmaceutical companies, including Alnylam, Eidos, and Pfizer, but I am not recommending a specific therapy from those companies. So I think I don't have anything to disclose. So I know there were prior speakers that probably had a comprehensive discussion about what amyloidosis was and the different types, but this is just a brief recap as we move forward with my presentation. So we know that amyloidosis in general, there are different types. It's a sticky substance, starchy substance that attacks, that is developed in the liver and travels and affects different organs, including the heart, the nerves, and the autonomic and neurological system. There are primarily two types that affect the heart. One of them is called amyloid light chain, which is primarily produced in the bone marrow, and it's a different type of pathophysiology. It's treated like a cancer with chemotherapy. It's a plasma cell dyscrasia. But we're going to particularly discuss today amyloid transthyretin that is produced in the liver. It is routinely diagnosed with either cardiac biopsy or a nuclear scan and genetic testing. And once we have the genetic testing, if you do have a genetic variant, you are classified as having hereditary ATTR. If you do not have a genetic variant, then we think that you have a wild type ATTR. And it's treated with different medications. And we're gonna focus not in disease management, but on symptom management. So, and then again, we're gonna be focusing on the hereditary type of ATTR. So cardiac amyloidosis affects the heart in two main ways, creating pump failure and arrhythmias. So with pump failure, as nurses, we are familiar with the clinical presentation of a heart failure patient. It includes shortness of breath, swelling of the legs, of the abdomen, low blood pressures, fatigue, nausea, vomiting, and weight loss. With arrhythmias, we know that patients are particularly affected with bradyarrhythmias, so slow heart rates, heart blocks, atrial fibrillation of flutters, ventricular arrhythmias, and DEAs. So how do we manage pump failure? You guys may be familiar with this particular graphic. This is the presentation of a heart failure patient. Now, just to recap, there are two different types of heart failure with reduced ejection fraction when the ejection fraction is less than 50%, and heart failure with preserved ejection fraction with the ejection fraction more 50 to 65%. The normal ejection fraction is 50 to 65%, but there are different cardiomyopathies or different changes in the heart muscle structure that classify this patient as having heart failure. Once you have heart failure, there are four different types of presentations. You could have pump failure, where the heart is not pumping effectively, and that's when we call the patient is hypoperfused. And you could be dry, you don't have to have fluid overload. You could be just cold. When you have a patient with congestion, with fluid build up, then we say that the patient is wet, and it could be again warm or cold based on the perfusion status. Most amyloidosis patients have heart failure with preserved ejection fraction. So we do not see a failure in the ejection fraction, which is the percentage of blood that is being pumped in the heart. But we see that the heart is becoming thick and ineffective. So most of them continue to have a preserved ejection fraction, but the heart is so stiff that I cannot pump effectively. Patients, routinely we have the clinical presentation of a heart failure with reduced ejection fraction. It's more common in nature, and there's a lot of research, and we have guidelines to treat that. But we don't have that with heart failure with preserved ejection fraction. And that's a problem with our cardiac amyloidosis patients because they are underrepresented in different clinical trials. And even when they're represented in clinical trials, we have not been effective developing therapies that improve their care. So we talked about hyperperfusion. So hyperperfusion is created due to the failure of the heart to pump effectively. Different organs like the brain, the liver, the kidneys. Sometimes it's it's presented with hypotension, but it's not always like that. You may have other symptoms such as the patient may be nauseous and vomiting because there's hyperperfusion to the gut. The patient may stop making urine because of hyperperfusion to the kidneys, or just getting confused with mental altered status due to hyperperfusion to the brain. Some of the medications that are used routinely for other heart failure types or heart failure that is not caused by cardiac amyloidosis are actually discontinued because they are not useful in cardiac amyloidosis. And so a lot of the side effects include low blood pressures. And if the patient is already having low blood pressure secondary to cardiac amyloidosis, obviously this medication should not be started on those patients. Sometimes actually patients end up on medications to raise their blood pressure, and that's including the alpha-1 agonists like midodrine, and that includes, that's to avoid falls on, in general hyperperfusion side effects. If you guys work in the hospital, nurses that work in the hospital may be familiar with inotropic support. Inotropic support are medications that help the pumping of the heart. They're intravenous medications only, and that's why you only see them in the inpatient setting. They include milrinone and dopamine. They are not routinely based on the heart failure or the ejection fraction percentage that we see on echocardiograms, but rather on a right heart catheterization that is used to visualize and measure the cardiac output and cardiac index. Some patients, as they move on through the trajectory of the disease, they may require inotropic support long-term. This is for palliative measures only, and they may leave the hospital with an infusion, with a pump for continuous management. And this is only to minimize their symptoms of hyperperfusion, but we know that it does not prolong life. And if they do have side effects like infections and primarily arrhythmia secondary to the heart being stimulated to do more. So increasing the pump function. So contrary to other types of heart failure like dilated cardiomyopathy, the traditional therapies, including the ACE inhibitors, ARBs, ARNIs, beta blockers, calcium channel blockers, are not of benefit in cardiac amyloidosis patients. And they should not be introduced to these patients, primarily secondary to hypotension. So I wanted to just show you a picture. This is a normal heart in an echocardiogram. We see the 4 beautiful chambers. The heart is strong, and there is normal diameter in the septum, which is between the 2 ventricles. In an amyloid or restrictive cardiomyopathy, you see how big the septum is, and this is why it's so fibrotic and stiff, and that's why it cannot pump the way it's supposed to be. There's another type of heart failure that is called dilated cardiomyopathy, and we see this enormous left ventricle, and it's a completely different pathophysiology. All these drugs that we see in the guidelines were made for these type of heart failure patients, so obviously they cannot be applied for this type of patients. So I wanted to just give you an idea of why some patients are not tolerating those medications, and this is the case of cardiac amyloidosis patients. So treatment is geared towards keeping the congestion out with diuretics, and particularly in this type of population benefits from this mineralocorticoid antagonist. They antagonize the effect of aldosterone that can lead to reduction of fibrosis and improvement in the function of the heart, healthy function. Those 2 medications primarily that have been used in clinical trials include spironolactone and eplerenone, and they have shown improvement in patient outcomes, reducing hospitalizations, particularly in patients with heart failure with preserved ejection fraction, which cardiac amyloidosis classify on this. Important thing, if you as a provider are going to introduce this type of medication to the patient, you need to make sure that you test for kidney function and potassium level because they do cause hyperkalemia. So within 1 week, you should try to check get labs, and again in 1 month. They're routinely not recommended on patients with a creatinine above 2.0 in women or 2.5 in men. And one of the side effects, as we are introducing these medications, is gynecomastia in men particularly. So if you have to choose between the two medications, eplerenone is known to have less gynecomastia as a side effect. So what are the signs of fluid overload? So now we know it's pump failure, or in addition to hyperperfusion, all that fluid that is not pumped throughout the rest of the body comes back and returns into the lungs, making the patient short of breath, goes into the liver, causing liver congestion, ascites, difficulty, digestion, nausea, vomiting, diarrhea due to the amount of fluid in there, and also swelling in the legs. Obviously a sign that that is happening is a rapid increase in the body. So we teach our patients that if they gain more than 2 pounds in 24 hours or 5 pounds in 1 week, that is not because you ate an elephant for dinner. It's actually because you're building up fluid. So important that you need to teach the patients that you see that they need to check their weight every day at the same time. Dyspnea or section because of the shortness of breath, early satiety, so feeling full earlier than usual when you eat, limited activity intolerance, paroxysmal nocturnal dyspnea. This is basically coughing or having trouble breathing when laying flat due to the congestion in the lungs and the heart. And one thing for those of the nurses or nurse practitioners that are perhaps doing physical exams, a lot of the things that we are taught in our nursing schools and our programs is that typical heart failure patient has crackles, has pulmonary edema. I want to say that that's only for patients with acute heart failure, the first time they develop the heart failure. As the patient has, chronic heart failure for many, many years, we see that they have compensated by improving their lung lymphatic system and draining that extra fluid to different areas, different pockets in the fluid, different areas in the liver. So they may have completely, be volume overloaded, but they may not have the typical rails that you see in pictures and in movies. So just to remember, the absence of rails or leg swelling does not rule out the acute decompensated heart failure status. Okay. So how do we treat it? So as I mentioned before, we treat it with diuretics primarily. One important thing is to treat the patient and tailor the plan of care to the patient's presentation, and this takes time. So in the hospital setting, you will probably see the patient that is being diuresed with IV diuretics. That's only done because, of course, you can check labs every 6 hours if you need to get all the congestion out. They send the patient out on oral diuretics. But what do you do when your patient comes to clinic and you see that the patient is volume overloaded? Well, number one, do not be afraid to raise the Lasix dose. If the patient is congested, you can raise the Lasix dose or the diuretic dose, maybe for just a couple of days. One of the things with cardiac amyloidosis patients is that they are preload dependent. That means that if we take that completely the extra fluid out, our ineffective ventricle will not be able to pump, will not have enough to pump out, and the patient could be hyperperfused that way. So we want to be gentle with our diuresis, but at the same time we can have them, drowning in fluid. So one of the tips and tricks that I can teach you today, hopefully, is that you may need to consider a diuretic sliding scale based on the weight. It works great for patients that are compliant, that that they're gonna check their weight every single day, and that you can tailor their therapy based on their gain weight. So I'm putting an example in there. Just if the patient, gains or is at 160 pounds one day, they can continue their Lasix 20 milligrams once a day. But if you start seeing weight gain, maybe they can increase it to double it up for just one day and they go back to the normal dose, or increase it again and then call the clinic. So those are basic instructions that work really well for patients that are compliant. Other things is that the most common diuretic use is Lasix or furosemide, but there are a couple more that are really great, particularly in those patients with chronic heart failure and chronic congestion. They include torsemide and Bumex. They're more bioavailable, and which improves the absorption in the gut. So they work a lot better, especially when we see patients that are chronically congested and develop what we call diuretic resistance. So what is diuretic resistance? It means that after a while, the kidneys develop a resistance to high dose diuretics, and you need to use higher doses to acquire the same or achieve the same diuretic effect. So we see this in advanced heart failure patients. But as cardiac amyloidosis is becoming a chronic disease rather than a lethal disease, we see that these patients are becoming more diuretic resistant throughout the years. So how do we do it? How do we manage? So one of the tricks that we do is to add a thiazide diuretic like metolazone as a booster pill. And I know in certain guidelines, the ACC guidelines, thiazide diuretics are used on a regular basis, on a daily basis, mostly for blood pressure control. But metolazone particularly has a half-life for 48 hours, and this should not be used daily unless you're monitoring the patient in the hospital setting. So it's a great diuretic. You will get the fluid out, but it also causes severe hyponatremia, causing confusion, right? Hypokalemia, hypotension. So you have to really sprinkle the metolazone around. And the one thing that I always do is consider increasing and maximizing the loop diuretic before adding the metolazone. So if the maximum dose, daily dose for LASIK patients is around 160 milligrams twice a day, and then I will add like metolazone 2.5 milligrams once a week, and then have the patient get blood work within 4 or 5 days. So I'm giving you examples because I know when you work in primary care practice, it's hard to kind of pinpoint like what dose do I use. So that's sort of the things that we do in heart failure clinic for our cardiac amyloidosis patients. What other things can we do? So therapeutic life changes. We do tell our patients to check their weight daily. And again, if they gain more than 2 pounds in 24 hours, we think that it's fluid buildup and it's time to do something about it. Other tips and tricks to increase your diuresis is the use of pressure stockings, leg elevation to promote venous return. Taking the diuretics and laying down, that's, is one of those things that it does work. If your patient is telling you, I'm taking my 160 milligrams of Lasix and it just doesn't work like it used to, ask them to lay down. That also helps when you're struggling with low blood pressure patients. Decreasing the fluid intake and reducing the sodium. So according to the guidelines, we should restrict the fluid intake to 2 liters a day and 2 grams of sodium. It's interesting that these two recommendations are in the guidelines. However, I actually participated in a literature review a few years ago. We reviewed over 4,000 studies, and there's no data that actually says that these two things reduce the congestion, but it's actually in the guidelines and we still have to teach it. I have seen that some patients are able to manage their fluid overload with just sticking to their restrictions, sodium and fluid restrictions, but most of them require diuretics at some point as they move through the trajectory of the disease. So just to review, fluid restrictions, they're different for everybody because if they have a renal dysfunction or they're on dialysis, they are actually more restricted. I think the restriction is to 1 liter, but for heart failure alone, it's about 1.5 to 2 liters a day. And we recognize fluids, anything liquid at room temperature, so water, tea, coffees, even ice cream because it melts, jello, sherbets, gravy, certain fruits like watermelon that are very juicy. So I'm not saying that they cannot have those things, is that if they're gonna include them in their diet, they need to cut back in their water intake throughout the day. And then same with sodium. So how many milligrams of sodium in a teaspoon of salt? Well, you'd be surprised that a teaspoon of salt is over the 2,000 milligram recommendation of sodium. So I know a lot of my patients say, well, I just sprinkle a little bit of salt, but actually that salt is too much salt because there are certain foods that already have sodium in them, like celery. Celery has a lot of salt. Eggs have salt. So there are different things that already have sodium, and we're trying to keep within restriction, and we're struggling with volume overload. We certainly cannot be adding sodium more sodium to the food. Salts and acquired taste, it can be done. We can all leave the salt behind. And, we try to tell our patients to, 2,000 milligrams a day is not a lot, but you can actually try to say, well, I'm going to do 500 milligrams per meal. It's different ways to kind of think about it and distribute this amount of sodium that you can eat in a day. There is no such thing as 0 sodium per day. Everything has salt. One thing that I want to mention is that salt is salt. I don't care if it's yellow, pink, black, from, I don't know, from the sea, from the Mediterranean Sea. Salt is salt, and we do not recommend it in the patients with heart failure. There's other, so we've discussed the management of volume overload, which is very typical with different patients with heart failure and those that have cardiac amyloidosis. But other symptoms include, shortness of breath due to pump failure, not fluid buildup. So we talked about pump failure before. What else can we do besides the inotropic medications that are put in the hospital? What can we tell our patients that are having shortness of breath? If they are euvolemic, they have no fluid overload, we can tell the patients to psychologically, use fans when feeling short or out of breath, elevate the head of the bed at night to help them breathe better. There are different breathing techniques, and we definitely recognize the use of Tai Chi and meditation as a daily practice. For those patients that have advanced cardiac amyloidosis, advanced heart failure, and they have this shortness of breath that is not due to fluid accumulation in their lungs. Fatigue. So fatigue is another symptom of cardiac amyloidosis when they throughout their trajectory. And so we tell our patients to avoid overexertion. They're going to have good days and bad days. And in the good days, they have to fight the urge to overdo. They should pace their activities throughout the day, combine low energy hobbies with high energy activities, and always ask for help. Once when you're diagnosed with cardiac amyloidosis, sometimes amyloidosis based on the genotype that they present, the genotype, they may also have neuropathy, peripheral neuropathy, or central neuropathy, which we'll talk about later. But they may not be able to do all the chores that they used to do. So it's time to find help. We also tell our patients that they to eat when they can, sleep when they can. Sometimes if you're after the hospitalization, your circadian cycle is messed up, and we need to at least have them, rest when they can to avoid the fatigue. Try to tell our patients to try to cook larger portions on the days that they have more energy, and freeze them up so they have meals to go through if they're too fatigued the next day, and always include protein and fat in each meal. So that takes me to nutrition and exercise. So studies have shown that frailty and cachexia worsen the patient outcomes in cardiac amyloidosis patients. So if a patient is anorexic, if they cannot eat, usually we've seen these patients when they are, late in the trajectory, we need to make every calorie count. So we tell our patients to use protein powders, powdered milk to increase the caloric intake and avoid muscle loss. We may need to modify or flex the dietary restrictions. If all they can eat is ice cream, we have to let them eat it, because the more cachexic, the more frail, the poorer the prognosis they may have. Some patients with ATTR and polyneuropathy may experience decreased mobility and falls. So we need to consider sitting exercises and referral to PT and OT as an outpatient or inpatient to preserve the mobility as much as possible. So we talked about preventing unintended weight loss. As we know, the heart is working overtime, and that increases the metabolic demand on the heart, and obviously we see it with patients becoming frail. So a few things in here that I always tell my patients, and this is from the American Association of Heart Failure Nurses, on how to avoid cardiac cachexia. So again, we're gonna try to eat hard-boiled eggs, snacks big on protein and fat, and gentle exercises that may stimulate the appetite and help prevent the muscle loss that we do not want in advanced patients. So how about autonomic dysfunction? So as we know, once you have amyloidosis, it may attach, the amyloid that is produced in the liver may attach to different organs, including the heart. It also the nerves, peripheral neuropathy. But it can also affect the autonomic system, which is the central neuropathy. Some of the symptoms include orthostatic hypotension, erectile dysfunction, and GI disturbances like nausea, vomiting, diarrhea, and constipation, sometimes all at the same time. It's very difficult. The prognosis is a lot worse in those patients that have autonomic dysfunction, particular or GI involvement of the amyloidosis. So we're gonna be focusing on reducing orthostasis. So the use of binders of TEDs really work well for those patients. Again, the use of medications such as midodrine also help. Usually, if you are using midodrine, if you're prescribing midodrine to your patient to raise the blood pressure, you need to ensure that they don't take it 4 hours before bedtime to avoid supine hypertension. So God forbid they have a stroke because they have too much blood pressure when they're lying down. So use it sparingly, but use it if the patients are, suffering with this. And then one of the things to remember is avoiding IV fluids. I know we're all taught that if the patient is hypotensive, let's give him IV fluids, it all works out. When a patient has heart failure, we will drown the heart. If the patient is not pumping well, he will not be able to tolerate that amount of fluid and actually will go into shock. So one more thing that to remember is, we have to treat the patients. Routinely, cardiac amyloidosis patients have lower blood pressures than normal, and we're trying to sustain those blood pressures. The body gets used to the low blood pressure, so unless they're telling us that they are struggling with orthocyclic hypertension, let's not add these medications until they really need them. So how about arrhythmias? So once you have amyloidosis in the heart, another thing that causes is arrhythmias. So all the ATTR patients should have an event monitor at least once a year. Amyloidosis interferes with the electrical conduction of the heart. So they have tachyarrhythmias or bradyarrhythmias episodes throughout the day. So maybe during the day they're active and their heart is fast, but as they go to bed, the heart rate really drops to the 30s. The only way to manage that, some people are symptomatic, some people are not symptomatic, but the only way to evaluate it for that is a tachybrady. It's a event monitor. Other ways that the amyloidosis affects the heart is something called chronotropic incompetence. And what all that means is that in a normal patient, as you walk or as they perform any activity, the heart compensates by pumping faster. When you have chronotropic incompetence, the heart is not able to pump faster because of the electrical conduction is interrupted. So these patients continue to, they're trying to run or they're trying to walk fast and the heart rate is still in the 50s. So we need to evaluate those patients. We can't wait until they develop a heart block and, faint. So the best way to do it is to evaluate for an event monitor and also teach our patients, monitor for signs and symptoms. Do not disregard any symptoms of lightheadedness or just fatigue, dizziness, palpitations, feeling of passing out. And also, they need to also take the medications as directed. So potassium and magnesium are routinely prescribed to counter-arrest the electrolyte dysfunction that may occur secondary to diuretics. They need to know that they are not vitamins, they're actually medications that are prescribed. There are some over-the-counter supplements. We do not recommend that. We actually like to prescribe potassium and magnesium to prevent, this type of issues. So the treatment of the arrhythmias is based on the type of arrhythmia. Not all abnormal heart rates, require treatment. But those that do, obviously, as we mentioned before, our cardiac amyloidosis patients do not benefit from beta blockers. They benefit from, and they have because of the side effects and the drops of blood pressure. So we can use routinely medications such as amiodarone and all the antiarrhythmics. We will need, or we will recommend an evaluation by electrophysiology. Digoxin is a common medication used in heart failure in the 80s. It's not commonly used right now, but it was thought to cause toxicity, especially on cardiac amyloidosis patients. So because there was a study that showed that digoxin accumulated in the amyloid fibrils despite the normal digoxin level, the normal serum level. That study has actually been repeated in actual patients, and through what we hear with the experts is that this recommendation may change, but at this time it's not recommended just yet. And another thing is anticoagulation. As we know, some arrhythmias like AFib, they have a higher risk for DVTs or for thromboembolic events. So we do have to consider anticoagulation. And the pathophysiology of amyloidosis in general places the patients at a higher risk for thromboembolic events. So we do recommend a discussion with, with an electrophysiologist or with a cardiologist as to what the risk benefit for anticoagulation is, despite of, the chest VASC score, as we know, that is typically used to decide whether the patient requires anticoagulation or not. And device therapies. So if we talked about the wearable monitors and the event monitors, but once you see that there is an arrhythmia that may need to be treated, a lot of our patients require pacemakers. Some patients now, as the world of amyloidosis evolves, as it becomes not a chronic disease rather than a lethal disease, some patients may be candidates for defibrillators. Routinely, the life expectancy has to be for at least a year before implanting a cardiac defibrillator. And before these novel therapies, that was not considered the case of cardiac amyloidosis patients. But now with novel therapies, now we have these patients living for a long time. So we do need to consider them. One of the typical arrhythmias is called non-sustained ventricular tachycardia. It's very common on cardiac amyloidosis patients, but it's usually not deadly. Unfortunately, most of our patients die with post-legs electronic PEA arrest activity, pulseless electronic activity. So unfortunately, a lot of our patients go that way, and a defibrillator will not shock a rhythm in PEA. So in summary, common therapies for heart failure are usually not of benefit for our cardiac amyloidosis patients, and they need to be avoided because of their intolerance and their side effects, including hypotension. Treatment is directed towards the prevention of volume overload with diuretics and sometimes aldosterone antagonists if the renal function and electrolytes allow it. Usually the management of a cardiac amyloidosis patient and amyloidosis patient in general requires a multidisciplinary team, including cardiologists, neurologists, nephrologists, and sometimes palliative care to improve patient outcomes. And if you see a cardiac or an amyloidosis patient in your practice, you definitely should consider using your community resources. There's a lot of support groups online or in big amyloidosis centers of excellence. And they do improve resilience and coping mechanisms on this population. So I encourage you to refer them. And that's it for us. Thank you so much.
Thank you so much, Dr. Fajardo. Would you mind making me the host?
Sure.
So you would hover over my picture and then 3 little dots should show up in the upper right corner. You would click those and then
make the host. Yep.
Yep. Awesome. Okay, so I will go ahead and share my screen to close things out. Just 1 second. Okay, here we are. Okay, and I will turn it to Lauren Edgar to close us out.
Thank you so much. I hope everyone who is joining us today really took heed to the information that was presented. A lot of great information regarding treatment was shared. And I hope that if there's anything that you leave with today, it's that amyloidosis is treatable. There's opportunities across the spectrum for treatment for people to live high quality lives. I want to thank our presenters, Dr. Fajardo and Dr. Ewing, for being with us today and sharing such great information that us as nurses can definitely look to use in our everyday practice. And I want to thank the collaboration between SNBNA and Harvard, as well as Pfizer. Thank you again. Dr. Johnson Glover, Dr. Hendricks-Stirrup, thank you again. Know that for those watching, you can see our contact information on the slide before you. Please feel free to reach out should there be any questions that you have based on the information presented in today's presentation. And with that, I want to thank you again, and I hope everyone has a safe evening.